Welcome everyone to our webinar, When She Needs It Most, Access to Reproductive Health Supplies in Humanitarian Settings. This webinar is co-hosted by the Interagency Working Group for Reproductive Health in Crisis and the Advocacy and Accountability Working Group of Reproductive Health Supplies Coalition.
Okay, yeah.
Okay. Welcome everybody to our webinar, When She Needs It Most, Access to Reproductive Health Supplies in Humanitarian Settings. This webinar is co-hosted by the Interagency Working Group for Reproductive Health in Crisis and the Advocacy and Accountability Working Group of the Reproductive Health Supplies Coalition. For those of you who are not that familiar with RHSC, the coalition brings together 444 members from across the total market for reproductive health supplies. They include multilateral and bilateral organizations, private foundations, low and middle income country governments, civil society, intergovernmental and non-governmental organizations, and the private sector. We bring together a diversity of partners and mobilize their collective strengths to increase access to a full range of affordable, quality reproductive health supplies in low and middle income countries. The webinar today will provide a background on the key reproductive health supply chain challenges across contexts affected by crisis, from emergency response to recovery and preparedness. On the agenda today, we'll have a couple of speakers, and we'll start with Sarah Rich from the Women's Refugee Commission, who will give us an overview on crisis-affected settings and the need for reproductive health supplies. After that, we'll go to Danielle German and Liz Nosneski, who will explain a little bit more on reproductive health supplies in emergency response. Afterwards, Nadia Olsen from JSI will give us some explanation about reproductive health supplies in recovery from an emergency. And last, we have Brainwin Miller from UNFPA Asia Pacific Regional Office to give us some more explanation about reproductive health supplies in emergency preparedness. At the end of this session, we'll also have a Q&A session with the audience. If you have any questions for the speakers, you can let us know in two ways. One way, you can type your question in the question box that you see in the lower corner of the GoToWebinar box. If you put your question there, the moderator will ask your question to the speakers. A second way is that you'll see a virtual hand that you can raise in the upper left corner of the GoToWebinar box. If you raise your hand, we can unmute you and you can ask your question yourself. I'd like now to give the floor to Sarah Rich, who's the Senior Advisor for Sexual and Reproductive Health at the Women's Refugee Commission.
Great, thanks. Okay, thanks so much, Emily, and thanks very much to the Reproductive Health Supplies Coalition for hosting the technology for this webinar. As Emily said, I work for the Women's Refugee Commission. I'm a senior advisor for sexual and reproductive health, and I'm also here presenting in my capacity as the co-chair of the Sexual and Reproductive Health Supplies Working Group under the Interagency Working Group on Reproductive Health in Crises, which we often call IWAG. Because I know some of the RHSC members on the call are probably not familiar with IWAG, I'll just give you a super quick overview of what it is. Like RHSC, it's a broad-based and collaborative coalition of agencies, including UN agencies, governments, non-governmental organizations, research advocacy, and donor organizations who come together aiming to advance the sexual and reproductive health of people affected by conflict and natural disasters. So I'm looking forward to bringing together these two groups, RHSC and IWAG, to begin thinking more about how we can improve access to SRH supplies in settings affected by crises. Emily started to mention this, but our objectives for the webinar today are really to provide some basic background to Reproductive Health Supplies Coalition members who are interested in crisis-affected settings. And the genesis of this webinar is really that there was some increased interest among RHSC members that was expressed to the facilitators of the implementing mechanisms following the Family Planning Summit last July, and some interest in thinking through how we could collaborate better together. So we'll have a series of 4 presentations today to talk about the critical SRH supply needs before, during, and after crises. And in the longer term, we do hope to kind of continue working together, both at the annual meeting in Brussels, where I'll be presenting, and through potentially some future webinars, to think about how we can develop linkages and really leverage expertise between RHSC and IWAG. Just to provide a very brief overview of crisis-affected settings and people, this will be kind of review for people from IWAG, but for RHSC folks, we are usually talking about 2 different types of crises, natural disasters and conflict, and most of the crises that we see around the world fall into one of those 2 categories. Both of them have been increasing. Over the past 2 decades, the number of natural disasters has doubled from around 200 to 400 annually. And at this point, more than 1.5 billion people live in countries at risk of natural disasters. So this is a threat that we see all over the world, regardless of context, really. But South and Southeast Asia do tend to have the most number of disasters or displacement in terms of absolute numbers. On conflict, we've seen that internal displacement associated with conflict and violence has been on an upward trend since 2003. So at the end of 2016, the total number of people who had been who were living forcibly displaced worldwide was 65.6 million. And that includes about 1/3 refugees, so people who crossed a border at 22.5 million, and 2/3 internally displaced persons or IDPs at 40.3 million people. And I think that a lot of times when we think about a humanitarian crisis, we think about something that's really temporary and then things go back to normal. But it's worth mentioning that due to a number of complicated, often political factors, oftentimes displacement lasts much longer. And in fact, the average length of displacement due to a conflict is actually 17 years. And I think that this changes how governments and local and international actors see the issue. As not only a humanitarian issue, but also as a long-term development issue that requires, sustained engagement across a diversity of national and international actors. Okay, I wanted to show this map. So this map shows new internal displacements associated with conflicts and disasters over 2016. We don't yet have the 2017 data yet. To give a little bit of context for where these crises tend to be occurring and which types of countries are most affected. I'll start by saying that poverty and vulnerability to crises are very much linked. So in low-income settings, many of the kind of development settings where the Reproductive Health Supplies Coalition members, those also are often the same countries that are vulnerable to crisis, whether natural disaster or conflict. So I did want to kind of highlight some of these countries in the Reproductive Health Supplies Coalition with strong participation that do face crisis. So we've got Nigeria and the Democratic Republic of the Congo and India and the Philippines with very high numbers, and Bangladesh as well, with very high numbers from 2016, and some of these other countries that I circled that I know have strong participation from RHSC members. With so many women and girls displaced globally, meeting their reproductive health needs is not just important for the humanitarian sector, but also critical to meeting countries' Family Planning 2020 commitments and Global Development Goals, or SDGs. And I see this playing out in a couple of ways. The first is that when a humanitarian crisis occurs or is in a prolonged state, this tends to stall or reverse development gains. But there are ways that this can be minimized, which some of the presenters will talk a little bit more about in the rest of the webinar. So ensuring access to reproductive health supplies across this humanitarian to development continuum can kind of safeguard gains that were made in reproductive health, commodity security, and service availability from being rolled back during times of crises. I'll also note that the potential for reaching additional voluntary family planning users across crisis contexts is great, because there are many countries like DRC and Pakistan and Nigeria that host millions of displaced people where contraceptive prevalence tends to be very low. So what happens to sexual and reproductive health needs during a crisis? I think the most important thing to remember is that routine sexual and reproductive health needs don't disappear in the midst of a crisis. So people still continue to have sex, and women continue to get pregnant, unintended or intended, and childbirth continues even during times of instability. So we see that at the same time, people tend to have less access to health services during times of crisis, whether because facilities were destroyed or healthcare workers are not available, or because it's difficult to get to health facilities, or because the supply has been disrupted. So women and girls tend to face disruptions in their access to reproductive health commodities, including family planning commodities. So women and girls who are affected by crisis tend to face an increased risk of unintended pregnancy, as well as maternal morbidity and mortality, including unsafe abortion and sexual violence. Within this context, we see that many women and couples want to space or limit the number of pregnancies following displacement. So a couple of studies on this showed that across 3 contexts in Africa, 12 to 35% of women said that they did not want any more children, and an additional 30 to 40% said that they did not want to become pregnant in the next 2 years. So you have a pretty high percentage of women who are reporting currently not wanting to get pregnant. And in some settings, this can actually be even higher. At the same time, we see, based on family planning programming, that demand for the full range of contraceptive options, including long-acting methods, is present in humanitarian settings, and that women will use them if they're available and of good quality. We do know that supplies continue to be a major gap across the range of humanitarian settings. The Interagency Working Group for Reproductive Health in Crises undertook a global evaluation a few years ago, comprised of 7 different studies aimed at providing a snapshot of reproductive health services in humanitarian settings, and it found major gaps in commodity management and security. And this manifested in frequent stockouts across the board, as well as in major challenges in transitioning from providing minimum reproductive health services at the outset of an emergency to providing more comprehensive services as a crisis either becomes more prolonged, or as settings move back to like sort of a recovery or stable development phase, and particularly in terms of making the transition from the supplies angle. We've done some research, which we'll get into much more detail on in future presentations, that show that there are really gaps that would improve commodity security around policies at the national and international level, guidance, capacity, coordination, and funding. So what can we do about this? There are a number of entry points to improve sexual and reproductive health supplies in humanitarian settings. So I have here what's often called the emergency management cycle, or sometimes the disaster risk management cycle or emergency programming cycle. There's some different terminology, but they kind of all get at the same thing. And this is kind of how people in the humanitarian sector think about the phases of emergencies. And I think it's most helpful to think about the entry points when we look at it in terms of the different phases of an emergency. So the next presentation in this webinar will focus on emergency response, including some of the key stakeholders, UNFPA and the humanitarian agencies that mobilize to get supplies as quickly as possible where they need to go in a new crisis. The next presentation will focus on the recovery phase. So after the acute phase of a crisis, things may settle back, go back to normal, or they might kind of settle into a more prolonged period of crisis. But either way, we want people living in those settings to have access to comprehensive reproductive health services and supplies. And this can be a big challenge for the humanitarian sector, and I think an area where we are particularly interested in leveraging the expertise of the Reproductive Health Supplies Coalition. And the last presentation in our webinar will focus on the preparedness phase. So what can be done before a crisis to ensure that sexual and reproductive health commodities are available throughout the crisis, and to ensure that we don't roll back gains that had been made during stable times in the midst of a crisis. There's also, I think, a lot here for collaboration between the IWAG and the Reproductive Health Supplies Coalition to continue discussing. Across all of these areas, I do think that there are really areas that we can link better between the Reproductive Health Supplies Coalition and the IWAG. We do have quite a bit of global guidance already in place. So I'm showing here on the top right a photo of the Interagency Field Manual on Reproductive Health in Crises, which is developed by IWAG and which provides guidance on what to do from a reproductive health perspective in a crisis. It includes the minimum initial service package, which is the set of priority actions that should be taken immediately after a crisis to provide the most basic set of reproductive health services to people. We are in the midst of revising the Interagency Field Manual and the minimum initial service package. And for the first time, the Interagency Field Manual will actually include a chapter on reproductive health supplies, which was based on requests from the field. So this manual will now include some global guidance, but there are quite a lot of opportunities still at the global level as well as at the country level to continue to improve the guidance and the policies and the capacity around supplies. I do want to continue to discuss all of this with all of you. So at the bottom of this slide, I've noted to please stay tuned. We'll be hosting a panel at the Reproductive Health Supplies Coalition meeting in Brussels, in which I'll get into much more detail about some of the challenges that we've found in supply chain management in crisis settings and further entry points and opportunities to work together. And if there's interest, we can definitely do more webinars targeting the Advocacy and Accountability Working Group and possibly the Systems Strengthening Working Group under the Reproductive Health Supplies Coalition to start to think more about what we can do together. If you have suggestions for what you'd like any of these webinars or presentations to cover, please do feel free to let me know. Thanks so much. And with that, I will turn it over to our next two speakers.
Our next speakers are Danielle German, Sexual and Reproductive Health in Emergencies expert at UNFPA, and Liz Nosneski, Senior Program Advisor for Sexual and Reproductive Health in Crisis Settings with CARE. Danielle and Liz, the floor is yours.
Hello, everyone. This is Elizabeth Nosneski from CARE.
And I'm Danielle German from UNFPA.
So this presentation will talk about the use of sexual reproductive health supplies in the initial emergency response after a crisis. During crises, it's common for health systems to collapse, supply chains to break down, health facilities to be damaged or destroyed, health personnel to be displaced, and for people to be cut off from health services that they need. As a result, we need to ensure that essential drugs, basic equipment, and other supplies that are needed to implement the minimum initial service package is crucial to ensure that essential sexual reproductive health services are in place from the very onset of a crisis. Being able to ensure the availability of these commodities in a timely manner comes with a number of significant logistical barriers. One way to address these barriers is through the provision of prepackaged kits that include the medicines, devices, and commodities necessary to provide life-saving services in the immediate aftermath of a crisis. The Interagency Reproductive Health Kits for Crisis Situations are a set of prepackaged emergency health kits that include all of the medicines, devices, and commodities necessary to provide basic minimum life-saving services at the early phase of a humanitarian emergency. The first iterations of the reproductive health kits were implemented by different international organizations, first in Bosnia in 1992, in Albania in 1997, and in the Great Lakes region in 1997. These experiences led UNFPA to produce standardized set of reproductive health kits for use by humanitarian agencies. These kits were intended to speed up the provision of appropriate reproductive health services in emergency and refugee situations. And the first version of these kits became available in June 1998. UNFPA has been managing these kits on behalf of the Interagency Working Group since their creation, and they've been updating them every few years to ensure compliance with the latest evidence and to solve logistical bottlenecks. Currently, there are 12 individual kits that can be used independently of the entire kit that respond to particular reproductive health service needs. These kits are designed to be used by health professionals and provide the necessary medicines, devices, and commodities required to implement the life-saving services outlined in the minimum initial service package. So as we know from the minimum initial service package, the current objectives of the kits are to reduce HIV transmission, prevent and manage the consequences of sexual violence, prevent excess maternal and neonatal morbidity and mortality. 4, to ensure the availability of contraceptives. And 5, to provide syndromic management for sexually transmitted infections. These kits are meant to support the provision of the most life-saving interventions and are not meant to be context-specific or comprehensive. These kits are
designed for specific levels of a health system and for specific population sizes for a period of 3 months. Not all countries will need every RH kit, and not every RH kit can be implemented in every context. The kits are broken down into 3 categories. The first category supports the community and primary healthcare level for 100,000 people for a period of 3 months. The second category of kits are aimed at the health center or hospital level, supporting a population of 30,000 people for 3 months. And the third category is for referral hospitals that cover 150,000 people for a period of 3 months. It's important to remember that these kits are designed for the use in the early phase of a humanitarian emergency. Some of these medicines and medical devices that are contained in the kits may not be appropriate for all cultures and contexts. This is inevitable, as these are standardized emergency kits designed for worldwide use. Despite the RH kits being designed for the early phase of a humanitarian emergency, the increase in protracted crises worldwide lead to the RH kits being procured for longer and longer periods of time. As soon as possible, humanitarian operations should begin to reestablish sustainable supply lines to procure context-specific and needs-driven commodities. When looking at how the kits are ordered, the Interagency Reproductive Health kits, while managed by UNFPA, can be procured by UN organizations, INGOs, national authorities, or other humanitarian actors. They can be ordered directly from UNFPA's Procurement Services branch in Copenhagen with the support of UNFPA country offices and headquarters. And they can be funded either through your own agency resources or through UNFPA funds. Before ordering the kits, it's important to undertake a rapid assessment of the local situation to confirm that the RH kits are needed, what types are needed, and where they are needed. You then base the quantity and type of the RH kits on the population size to be served, the location and types of health centers, and the skill of providers in those centers. There are Excel-based tools that have been created to support this process. There are 2 different kinds of procurement orders that you can make for the kits. Emergency procurement, which are meant for onset crises or new influx of people that are meant to arrive in country 2 to 7 days after the finalization of the final budget allocation. And then there's non-crisis procurement, which are meant for protracted situations or pre-positioning procurement purposes, which would arrive 10 to 12 weeks after the finalization of the budget allocation. This difference is because UNFPA procurement has on hand at all times pre-packed, pre-positioned stock of RH kits in the Netherlands in the event of an onset crisis. If a partner is procuring in a protracted situation, these kits are packed from scratch. UNFPA is continuously trying to balance the demand for kits and the risk of holding too much stock that could expire. We're constantly seeking feedback from partners on the quality of the kits, shipping, and the products. Every few years, we conduct a large-scale review, and one has just been completed in 2017. I will also speak on this at the upcoming RHSC annual meeting.
Okay, so to give you an idea of what this all on the ground. I'm going to present a program example from CARE's emergency response in Nepal. On April 25th, 2015, a major earthquake measuring 7.6 on the Richter scale struck Nepal. This was the deadliest earthquake in Nepal's history. Nearly half of health structures were damaged or destroyed. In May, CARE partnered with UNFPA to implement the minimum initial service package in crisis settings in 3 remote, severely affected districts. We supported the delivery of life-saving sexual reproductive health services through SRH camps to provide comprehensive services for sexual reproductive health and gender-based violence. 2, maternity centers and transit homes. And 3, female-friendly spaces to provide information, counseling, and referrals to women for sexual reproductive health and gender-based violence. Since supply chains and SRH supplies were damaged by the earthquake, CARE distributed RH kits to district health offices and service delivery points such as district hospitals, health centers, the camps, and the maternity centers. This was the first time that CARE ever used the reproductive health kits in Nepal. CARE ordered 114 individual RH kits from UNFPA for the emergency response. We received 23 of these kits immediately from UNFPA's pre-positioned stocks in Kathmandu. And we ordered the remaining 91 reproductive health kits from UNFPA procurement services in Copenhagen. CARE contracted logistic companies to transport the materials that we received in Kathmandu to CARE's district warehouses where they were stored prior to distribution. And ultimately, CARE distributed the RH kits to 30 different service delivery points in several distributions between May and September. So during this process, we encountered several different challenges related to the reproductive health kits. The first challenge was that it took longer than expected to get the kits. Although CARE received 23 kits at the outset from pre-positioned stocks, the remaining 91 kits did not arrive until late June and early September. And this was due to a few factors, including the shortage of pre-positioned reproductive health kits at the global level. That meant some of the kits had to be assembled from scratch. A second challenge was that CARE logistics staff in Kathmandu did not have any experience with the reproductive health kits. And as a result, we did not plan sufficient warehouse space, and some of the items had to be stored in CARE's office in Kathmandu, which was, as you can imagine, not very well suited for the purpose. And the third challenge was the monsoon season, which coincided with the emergency response. Landslides, mud, and a shortage of four-wheel drive vehicles made it difficult to transport the kits from the district warehouse to the service delivery points. So through this experience, we learned several important lessons. One is don't rely on reproductive health kits to meet all the needs in an initial emergency response. That we should procure sexual reproductive health supplies and equipment from local vendors as early in the response as possible so that we can offset any shortfalls in the reproductive health kits. A second important lesson was that procurement and logistics personnel must be trained to order and to manage the reproductive health kits. It is not sufficient to train only program staff or those emergency coordinators on the minimum initial service package. And this should be done in collaboration with UNFPA and the Ministry of Health as part of emergency preparedness. And the third lesson was that stockouts are not always due to the lack of commodities. In Nepal, district warehouses had plenty of contraceptives and sexual reproductive health supplies after the earthquake, but health authorities could not deliver them to the service delivery points due to lack of transport. So CARE helped to bridge that gap.
There are also a number of logistical challenges that are specific to the provision of emergency medical kits, including the RH kits in emergencies. Because of the instability and unpredictability of humanitarian and fragile contexts, it's often difficult to predict need. This is particularly the case in contexts with weak population figures, migrating populations, or large portions of areas inaccessible to humanitarian actors. Overordering can occur due to lack of understanding of the context and purpose of the kits and difficulties transitioning back to sustainable supply lines as soon as possible. This, followed by in-country regulations on the importation of medical commodities and difficulties in last-mile delivery due to the terrain or the crisis itself, can delay kits reaching the health facilities. The lack of prioritization of data collection in fragile settings and the numerous logistical challenges for conducting research in these settings continues to leave a gap in high-quality data to program from. This gap in reliable data makes conducting adequate needs assessments difficult and can negatively impact programming, monitoring, and advocacy. Medical supplies in emergencies is very difficult because of short expiration dates, cold chain requirements, regulations in country on medicines, and few suppliers pre-qualified around the world to procure from. Additionally, medicines may not be on national essential medicines lists. There's a significant lack of medical logisticians and pharmacists to procure and manage in country. Those currently doing the procurement and management have a lack of training on ordering and using the kits, leading to an ineffective use of the commodities. It continues as well to be difficult to get donors to fund improvements on logistics and ordering, be it structural improvements, training, or training of personnel. Finally, fragile settings often have weak waste management, especially medical waste management, and this is often not taken into consideration when planning for the kit procurement. In conclusion, logistics challenges due to the crisis, particularly in the early phase of a humanitarian response, exacerbate existing difficulties in delivering timely supplies at the last mile. It is important for UNFPA and IWAG partners to learn from the expertise of the RHSC in order to improve these services that we provide. So when looking at how we can work together, we've put forward a few things, which are helping to solve the supply chain challenges related to the RH kits in acute emergencies, supporting efforts in preparedness and pre-positioning of SRH supplies, facilitating the transition from RH kits to sustainable national supply chains for SRH supplies, and making supply chains for SRH more resilient to crises in the first place. Thank you.
Thank you. Our next speaker is Nadia Olsen. She's the Senior Technical Advisor at GSI, and she will give us an explanation on reproductive health supplies in the recovery from an emergency. Nadia, the floor is yours.
Thank you very much. It's a pleasure to join this webinar today. I'm happy to be here and hear the other presentations as well in terms of what goes on in the various stages of a crisis. I will focus a little bit on what happens in the later stage of a crisis, moving on to the recovery phase, and some of the challenges involved in the process of transitioning from an emergency or a crisis situation to a recovery and development approach to supplying products after the crisis, during and after the crisis. Excuse me, I'm having trouble with the controls. Okay, I'll give a little bit of information on the context. As we heard from the previous presentation, the world is changing in terms of the crises, increasing number of crises, and they are becoming more frequent, more complex, and many of them are longer lasting and further reaching. Populations are moving around quite a bit, as we know, from the Syria crisis, for example, and many other, the Rohingya crisis in Bangladesh. And they are not only moving into camps, but they are also moving into communities in other countries nearby or far away. In terms of providing services to populations, displaced populations that are moving, it's becoming increasingly complex. Also, in one country, you may have a crisis in one region, whereas the rest of the region will be continuing to operate in a development context rather than the emergency context. So you will have multiple situations happening in one country. And all of these changes in the context really affect the way we've been providing the emergency reproductive health kits historically, and how to transition from the process of providing the reproductive health kits to ordering supplies in a more institutionalized way over time. I'll review some of the challenges that have already been described a bit. In the process of moving from the emergency situation and on to either a protracted crisis or a recovery, we find that there are a lot of factors that complicate the ability to provide the supplies, and there are multiple actors operating in one context at the same time. So we'll have interrupted or duplicative financing. The forecasting methods, for example, are conducted often organization by organization, and so the hopes of having a national forecast can be challenging. Of course, the data is complicated in these settings, and also some of the methods that are used to forecast are different, whether it's a humanitarian or a more stable situation. And it would be wonderful if the different actors could learn from one another about the different forecasting methods and then aggregate those forecasts to have a better sense of what the need is across sectors, even across regions, sometimes across countries. Which is another complicating factor. For example, the Syria crisis, there are multiple countries responding, multiple countries procuring, and it's a multi-country forecast, really, when you think of all of the displaced people living in the surrounding different distinct countries that are all providing services to these populations. There's an inconsistent use of inventory management tools. Again, it's organization by organization. The policies and procedures are different across the different organizations providing supplies. Sometimes there is limited clarity on what those procedures are, those international procedures, what the best practices are. And then again, there's a difficulty in understanding how to transition between the process of ordering and supplying kits directly to a system that would be ordering product by product. There's a lack of guidance again on the procedures and how to ensure the quality of products. For example, a country may be getting automatically the reproductive health kits and rely on the quality control measures that are used to ensure that those products are safe. But as they transition to a national solution, it's possible that for some of those products, again, like Danielle said, they may not be registered, and then the quality control procedures may not be in place at the national or the regional level. It's also possible in some cases that the national procedures are more rigorous than the international procedures, which can also interfere and create a process of slowing the supply and having sort of a lack of harmonization between the different types of quality control regulations between countries or between the organizations. Again, the overlapping supply chains, multiple supply chains operating in one country, operating via multiple different organizations. The transportation routes may be duplicative. You may be having more than one organization responding to the same region and some of the same products going to the same place because it's an immediate crisis, so it's not always possible to map everything and where everybody is going. In the transition to recovery, there's an effort, of course, to get a sense of who's going where and better align that under the government system so that there is a more strategic response. There's gaps in the data and information systems, a lack of an information system. And ultimately, at the very big macro level, as we rely on the humanitarian response or the reproductive health kits, for example, there can be a process in the transition either to the developing system where we get a risk in a drop in attendance. We saw this in DRC. There's an example from UNDP where they saw that there was a bit of a drop that was later resolved, and then the sustained humanitarian delivery, sometimes the dependence on the reproductive health kits will substitute the normal supply chain, which progressively weakens the health system. And sometimes also when you transition, because the international organizations in the humanitarian setting may require more stringent accountability, sometimes there's a loss in the accountability. But again, sometimes it's the other way around. It may be that the government is stricter on accountability, but there's just a process of, in that transition, losing accountability and having to gain that again over time. Some of the solutions that we've been exploring across the community through the IWAG is thinking of having more reliable data, sharing that data across organizations, having a better sense, again, of the different types of methodologies for doing forecasts and sharing those methodologies across the organization, and then making sure that the government institutions and the other actors that are strengthening and supporting governments on the development side are familiar with these methodologies and can be shared across both the development environment and the humanitarian response. Sometimes you'll have a completely siloed approach to forecasting or supply planning or any of the supply chain functions, depending on which sector you're working in, with zero communication. So the idea would be to share that data and come up with a more harmonized approach, even if we're using demographic patterns or service data, because we don't necessarily always have consumption data or what the populations are consuming at the last mile level, but we can come up with good methodology regardless. It's important to develop guidance for how to move to the recovery phase. These guidance are currently not available. There's many different ways that countries have responded and are doing this work, but it hasn't necessarily been compiled in terms of what's the best practice. And this remains to be done in the field, including really how to move and ensure that all the products, again, as Danielle mentioned and the previous presentation, how to ensure that all the products in the kits are registered at the country level, are on the essential medicines list, that they're in the policies, and move from the MISP application and the emergency reproductive health kits to a more comprehensive SRH approach. And again, in a country, you could be moving back and forth. You could have a stable situation, move to an unstable situation, and then move back to a stable situation. We saw that very much in Haiti, and some of the work there undermined really systems that had been previously in place, and many of you are familiar with those examples. It's important, of course, to refine the supply chain roles and responsibilities among all the partners, including who's financing, procuring, ordering, and again, the transportation paths. Increase the data visibility into the supply plan so we know who's ordering what and delivering what, even if it's across the public and the private sector, including NGOs, and make sure that some of this information gets shared back upstream to the manufacturers, because there's also a big problem with product availability globally. Manufacturers aren't able to supply or produce the product quickly enough to respond to the demand, and UNFPA and others that are working at the global level are faced with lack of stock availability globally. If we had data upfront earlier on, then of course the manufacturers can prepare and produce longer. And we've learned a lot on the development side through the coalition on how to coordinate supply plans to make sure manufacturers can supply, also how to coordinate and have financing mechanisms that ensure framework agreements with those manufacturers to make sure that those products are available in the long term. It'd be great for the humanitarian sector to be able to benefit from some of that experience. This I'll just briefly go over, but it just shows the different phases of a crisis. And the idea here is that there are different assumptions for what demand will look like across the different phases, and forecasting methodology and assumptions will have to change across those. And there's been a lot of research and analysis, but nobody has necessarily yet developed methodology or standard harmonized methodology that we can use across the different phases to forecast supply and have a better sense of how this demand goes way up during an acute phase, stabilizes during a chronic phase, and then afterwards you'll see a bit of a decline, but it can really be complicated by the mobility of the population, who's coming and going. So it's difficult to predict, and forecasting in this environment is quite a challenge. But we can improve and learn from the best practice and apply that, and it remains to be done in the field and learn from one another, and then move again to the recovery phase and a more institutionalized forecasting methodology. Again, good supply chain good supply chain practices can be adapted in the recovery phase. Some of the same things that are happening in the development sector can be used in the humanitarian sector and vice versa. It is the same best practice that we see in the development sector, but of course complicated by movement of the populations, difficulty of coordination, the need to have an integrated supply chain from the very top, the manufacturers, all the way down to the last mile, and have industry standard max minimum inventory control procedures, but also dynamic. And you may have more than one supply chain operating in a country with different maximum and minimum inventory control procedures. And this is what we would call segmented supply chains, to ensure that we're responding to very different needs depending on where in the country we are facing an emergency and where in the country we may have a more stable situation. And overall, at the end of the day, we're going to need to develop guidelines and capacity building tools, including trainings, that can help countries better pre-position and have a better sense of what the best supply chain practices are, especially in the time frame in which the country is bridging the emergency and moving on to a more institutionalized system, and also going back and forth if the situation is unstable or temporarily unstable and then returning, so we don't undermine our institutionalized systems over time. There's a quick example from Nepal. I won't spend too much time on it, but this is an example of a product that was introduced during the earthquake, chlorhexidine. It was not originally included in the reproductive health kits. It is now, and what happened was it served in the emergency to really respond to neonatal mortality and reduce neonatal mortality. It eventually was included in the kits, like I said, and it was scaled up during and after the emergency all the way across the country. So it is a product that was introduced during an emergency, but during the recovery phase was able to be completely institutionalized into the government and also back into the emergency response and the relief situation worldwide in terms of being a product that can now be delivered through the kits. Ultimately, at the end of the day, we really need, in the grand scheme, on the humanitarian side and the development side, there's a global conversation about the nexus between development and humanitarian. And there's a lot of global guidance about how we need to get better at coordinating across platforms for all partners, improving planning, and really accelerate development planning and emergency development and broaden the horizon of humanitarian action to address the midterm, instead of only thinking about the acute phase, and then putting the SDGs at the center and ensuring harmonization. The SDGs are consistent and compatible with the humanitarian principles that are being set forth in global guidance documents, prevention and preparation, which we'll hear in the next presentation. And in terms of the money, with donor support, the UN and other organizations must better integrate their funding for joint programming and ensure that the funding streams are not inconsistent, and also the requirements associated with those funding streams and the timeline. One big thing that could happen to support emergency reproductive health products is having money or a credit scheme upfront where countries can order supplies even though they may not have that funding upfront, which is a challenge we also saw on the development side with reproductive health supplies, and the need for some sort of revolving fund or some way for countries to get the product quickly, even if they don't have the money upfront, and then pay afterwards. So thank you very much for your time, and we can move on to the next section.
Thank you, Nadia. Our next and last speaker is Branwen Miller. She's a humanitarian project coordinator at UNFPA Asian Pacific Regional Office, and she'll give us a presentation on reproductive health supplies in emergency preparedness. Branwen, the floor is yours.
Thank you very much, and good evening from Bangkok, everyone. I manage a regional humanitarian preparedness initiative that is funded by the Australian government that looks to pre-position life-saving sexual and reproductive health and gender-based violence supplies across disaster-prone countries in the Asia-Pacific region. So the basic idea is that we procure modest amounts of the supplies that UNFPA frequently uses in humanitarian response, many of which have been talked about tonight. So the reproductive health kits, also tents that can be set up as maternity units or women-friendly spaces, dignity kits, reproductive health medical missions, supplies, and other items depending on the country context. And we stockpile those supplies in warehouses in disaster-prone countries across the region where they're kept and then used when a disaster hits, so they're immediately available. In this presentation, I'll share a few examples from this initiative and some of what we've learned through pre-positioning supplies. So any humanitarian will agree that preparedness is key to assuring an effective and an efficient humanitarian response. It's also cost effective, with every dollar invested in preparedness saving $4 to $10 or more on recovery, depending on the intervention and the study that you look at. We can measure the effectiveness of a response, perhaps, in three ways. Firstly, how quickly we're able to meet the needs of the affected population, or the speed of the response. Secondly, how many of those affected we're able to reach, or the scale of the response. And finally, how well we meet their actual needs, or the quality of the response. Pre-positioning sexual and reproductive health supplies as part of preparedness greatly improves both speed and quality. Speed is somewhat intuitive. If the supplies are already on the ground, they can reach people far quicker than if you need to find the funding for the supplies and then order them and hope what you need is available, and then transport the supplies from wherever they're manufactured into the country and then clear them through customs. And that's all challenging in the midst of a response. But pre-positioning is equally important for improving the quality of a response. In general, people take what they can get in an emergency. Even if you want a specific type of drug or a specific type of reproductive health equipment, you'll take the closest thing available that you're able to get your hands on. While UNFPA's general interventions in emergencies are fairly standard across the board, there are aspects of any response that are specific to the country context. Some of our country officers deal with such regular emergencies that they know exactly what they will need and how it will best support the response. And the preparedness moment is the only time when you have the luxury of time in the disaster cycle, which when you have time, you can improve quality. So just to share a couple of examples, the Philippines is one of those countries that deals with multiple emergencies a year: cyclones, volcanic eruptions, earthquakes, conflicts, and that's just in the last 6 months. So I wanted to share two very short stories from the Philippines that demonstrate earthquakes, conflicts, and that's just in the last 6 months. So I wanted to share two very pre-positioning supplies. Sorry, there was a feedback. Pre-positioning improves both the speed and the quality of a response. When conflict broke out in Marawi City in June, hundreds of thousands of people were displaced. UNFPA received a request from the government on Friday evening, and supplies were loaded from our warehouse in Manila and transported to Iligan City in Mindanao, ready for distribution on Monday. Over the next few months, we were able to reach over 26,000 people through our integrated SRH and GBV response, one of whom you'll see in that photograph on the left, 17-year-old Asni Omar, who delivered her first baby while living in an IDP camp. UNFPA has also worked with the Ministry of Health in the Philippines to develop Philippine-specific sets of supplies, equipments, and medicines that are pre-positioned in a central warehouse. There are reproductive health medical mission sets that contain everything needed for a mobile reproductive health team, and maternity tent sets that contain everything needed to set up a basic maternity unit. You can see the tent set up on the right after the recent eruption of Mount Mayon volcano, and Giselle Balantisayo, who gave birth the day after it was set up with her baby there. Now, a very old example that's been touched on before, but this one's close to my heart, as the Nepal earthquake was in many ways our test case for prepositioning in the region. And really, this experience demonstrated how life-saving prepositioning SRH supplies can be. We procured supplies with the intention of prepositioning them in Nepal, and they arrived just a few weeks before the earthquake hit. We were really only able to initiate a rapid response due to the prepositioned supplies. We couldn't get anything else on the ground in Nepal for over a month because Kathmandu's single airstrip was being used for all humanitarian supplies coming into the country. And now a very recent example, current example. In the last 2 weeks, we've been responding to Cyclone Gita in the Pacific, the worst storm to hit Tonga in 60 years. Tonga is a tiny country and UNFPA has 1 staff member there. We don't actually have any supplies prepositioned in Tonga, but we do have a regional hub of supplies in Brisbane and a sub-regional hub of supplies in Fiji, where we put sexual and reproductive health supplies prepositioned to support all across the Pacific. I don't know how many people on this call have worked in the Pacific, but it is a long, long way away from most places, and it takes a lot of time and a lot of money to transport things there. We transported our modest quantity of supplies to Brisbane, from Brisbane and Fiji by sea, saving tens of thousands of dollars on transportation alone when we sent them to be prepositioned. They were on the ground within 48 hours of the request and 72 hours of the actual cyclone, thanks to the partnership we have with Australia. So we've been carefully documenting the lessons that we've learned through this initiative, and there are a number of things that should be taken into account with prepositioning as a preparedness measure, some of which have been touched on by other speakers. We obviously want to ensure that sexual and reproductive health supplies are well managed. And sometimes the pharmaceuticals that have specific storage requirements and expiration dates is beyond the capacities that exist in country. Last year in Myanmar, we ended up donating 3 sets of RH Kit 3, the rape treatment kit, to partners, not because there was an acute response, but because some of the contents were approaching expiry. And to mitigate against these risks, we preposition very modest quantities of supplies and really just what is needed in the first few weeks of a response before additional commodities can be brought in through traditional means. Secondly, in general, sexual and reproductive health logistics capacity is weak, another point that's been touched on by other speakers. Through the initiative, we are investing in training and capacity building for our own UNFPA staff, government counterparts, warehouse managers, and other partners. And this capacity building is essential. But if it's not already apparent by now, I am a strong advocate for prepositioning as part of preparedness measures. And I know from this initiative that improves both the quality and the speed of the response and also saves lives. Thank you very much.
Thank you, Brenwyn. We've come to the end of this webinar. Unfortunately, it took a bit longer than expected, and we will not have time for questions. What I would suggest is that we take up the questions that are put in the question box, as well as the questions that were put under the YouTube channel, and I'll discuss this with the presenters, and we'll put some answers on paper and share this together with the presentations and the recording afterwards. Also, it also would be great if we could discuss this further, especially the questions that Sarah put in the beginning on how we can collaborate more. If we can discuss this during our next Advocacy and Accountability Working Group meeting. I think this presentation have definitely showed that there's a lot of interest in this topic and there's a lot to discuss. So I really hope that this is not the end, but this is really the beginning of a stronger collaboration on the issue of humanitarian situations. So thank you everyone for joining us. We had a lot of participants in our webinar, so that was great. Special thanks, of course, for all of our speakers who did a great job and very clear presentations on the different topics. The As I mentioned, the recording of this webinar, together with the presentations and some answers to the questions that were raised, will be shared with you in the coming days. If you have any more questions for us coming up in a couple of days, then please don't hesitate to send it to me, Emily, at the RHSC Secretariat, and we can share it with the speakers. So thank you very much, everyone, and we'll hope to see you on our next webinar.